Next thing we want to do is to break down the 6 steps where you can see them all in action. And the number one is structure, so let's just talk through structure first. The 2 most important things that we do in spinal correction is are with the adjuster and the percussor, and it's a little bit different. Now the arthrostem was around before I was. It was developed by Ed Miller, and for the different doctors who did, they were practitioners. But the way it's used, I developed, and that's what we want to talk about right now. I studied Donstead, I studied Toughness, I studied Diversified, I'm advanced. I mean, I just studied just about everything that's out there through the years. About the only class I never took was DNFT, which is a very light adjustment. But I did Logan Basic, I did a lot of Cranial, and I found by merging everything I learned with the adjuster technique, I was able to get very fast, deep results, and painless on the patient and painless on me. And if you've been in practice, you've been over a patient for 40 or 50 years, it starts to show on you. So I wanted to develop a way where I can make massive corrections. And the corrections we make are specific, so you correct the subluxation, like an ASRA Atlas. Atlas, you go there, anterior, superior this way, looking at some of the side, the slit to the right, and then rotate it, all right? ASRA, SRP, whatever. So we correct that, but also the way we do it is the global correction, where you correct the whole body. So let's take it step by step. Doc, why don't you come up? Why don't you just sit here with your back to the public here. And if I'm going to make an adjustment with the patient, I'm going to use the adjuster. The adjuster is a mechanical unit, literally taps the vertebra into place. The harder you push it, the harder it hits. So the old joke is if they pay their bill, you hit them real light. If they don't, you keep increasing the pressure until they pay. But don't hit people too hard. Just so fast and so quick, it doesn't take a lot. The faster something is, speed overcomes resistance. So this is very quick, taps it in place much faster than we can react and the vertebra. So we do the whole full spine with this. When we go to the cervical area, we use the cervical probe. And these just pop off and in. You just pop off, they pop on. This matter we're using the adjuster or the arthrostem from different companies. This is cervical unit. This is for everywhere else where you want a broad topic area and you don't want to cause pain, but you want to make the area go in place. And this is for the atlas. If I'm evaluating a patient, then you do anything you normally do, a leg check, x-rays, whatever you want to do. Then I almost always, with a patient, whether it's first visit or 10th visit, I see what kind of range of motion they have. He's already been around a while, so he has pretty dang good range of motion. If he didn't have, and I make the correction, it's very impressive that they see how much better they are. Now flip and face me over here. He's in a group practice that does this work, so that was very impressive to see it's working. If I'm going to adjust the spine, I do the broad forward here. What I'm doing is I'm going along the whole spine, literally starting at sacrum 2, and I'm going to end right about C7. So I come right here, it's right in the center. Now it's kind of disappointing to me when I see chiropractors sometimes, and they don't know where the spine is. They're over here, and they're like this. That's not the way it is. You're going all the way up the whole spine. So try to remember if they're adjusting the spine. So this will tap into posterior mechanical facets. As you know, the vertebra's here, and there's little blocking points coming from one down to the other to the one above. The only thing that doesn't have is axis with third axis or second cervical vertebra to atlas doesn't have any. That's why you never tap it from the posterior when you lateral. But you can go all the way down to sacrum 2, even though fifth lumbar is the last movable vertebra. In children, they're still movable, but that impulse is very good because sacrum 2 go right into the bladder area, so you can start there and end there. Just take a deep breath in. I pull the trigger and I never let off. I'm dancing. It's like this. So I breathe in and I walk all the way up the spine. So this taps all the posterior mechanical facets and also stimulates the bladder meridian to the side, which affects all the spindle cells in the body. I have to breathe in, I have to breathe out, and then I might have to do a rapid breath. Like that. So I'll go up and down 2, 3, 4 times just like that. And you say, well, that's just a shotgun approach. No, it's not. It's very specific because I'm affecting spine and spindle cell. And I'm making sure this helps the lumbar lordosis, the thoracic kyphosis, and the cervical lumbar, the cervical curve lordosis to be returned. So we're getting input and we're getting a balance, clear fixations and subluxations.
Could you do that prone? I find myself doing that a lot prone, breathe in, breathe out sensations.
There's nothing wrong with doing it prone. The only issue is the table holding you up a little bit. You're not getting quite the movement because the table has a little resistance against you. Goodhart had a famous saying, patients don't wear a table around all day long, so sometimes you need to. But there's nothing wrong with it, Dr. Jesse. Stand up for me. Another thing is, and turn you back to me here, where most of you can see it. Another thing you can do is have him walk in place and literally do it like this. Or somebody says, you know, I'm all right if I'm standing, though, that's what hurts, so I have him stand still. I'll do it like this. Or come back to the needle if you have a little space to walk. Okay, just take a slow step forward. I just do it like this. I literally have him do it walking. Or he says, you know, I hurt the worst. I hurt really bad down here. My job, I look up a lot. So have him look up a lot. Look up, and I'll do it while he's looking up. And walk in place. There's so many things you can do with here because of that. Okay, I'm going to sit back down here again. Now the cervical becomes a little more specific.
Can I correct me for cervical? I know I'm doing pretty well. Is that okay?
You want to be happy?
Good victim now. So here, what we're going to do is we also look at the shoulder height and like if it's like this, the head's like this. When I go to make the correction, I want to do the opposite. It's called mirror image. So I take the shoulders the opposite way. And if the nose is rotated this way and the shoulder's like this, when I adjust, when I do this and this. Whatever it is, I go the opposite way about the same amount. Fair enough? So let's say that
you're not bringing them just back to neutral. You go.
I go slightly exaggerated. I want to do affrontation in the exaggerated state. And so his head tips this way a little bit, so I'm going to go back here. The shoulder's a little bit higher, so I take it down and I go here. Just slightly exaggerated, slightly. Then I have the narrow cord here. I'm going to start at T2 now. I'm going to do straight P to A, of course. Then when I start going in the cervical area here, I don't do it hard. You don't need hard. You can actually cause an anterior subluxation. So I just slide and glide. Stop it at axis. Never go past axis. So I just slide and glide 2 or 3 times. 2 or 3 times. Slide and glide. Well, what happens if he's really stuck here? Heck, I might go through motion. Just like that. Because that's where a lot of us get it right there. Some small ribs in there, a lot of stress on the computer a lot. And I might want to do the same here. Let's say these really kind of put your hands behind your neck a little bit there. Like this. So we might want to just come like this and really work on this area here. That's a really good way of doing it. Once I've got that in place, I can turn it all the way opposite to what I'm palpating. And I'm going to come right down the neck. I slide right here and glide. There should be no knots at all. It should be smooth and even. Let's say I found a knot on one side or another. And some of you are not chiropractors, will not be doing this. You must be a licensed chiropractor, osteopath, medical doctor to do this. So if you're a reflex therapist, you'd be a victim, but you won't be able to treat with anybody like this. So let's say I find the knot right here. I turn this way and find it, and I keep my finger on it. I turn all the way till it stops. Here. You go to the range of motion where it stops, then I replace my finger with a big round ball. We call it Fat Albert. All right? And I find it, I just give it a love tap. Fair enough? So I find it here, I bring it back to me this way if there's a knot there, and I tap right into it here. Just like that. It's very gentle because when you go back, wow, no more knot. Okay, flip around faces over here.
Are you turning them away or towards?
The first time I showed that I did it backwards. I turned it away to find it, but when I corrected it, I turned it into me. I think the first time I showed it, I turned it backwards. So you turn it away to palpate it. To correct it, you turn it towards you and correct it right into there.
So the goose egg here you're trying to get rid of, are you trying to define what that is, where that's coming from? Is there
The big knot, the knot that's left is still a posterior vertebra. It's like body right axis.
So then what about the disc component?
That's what we're going to show you now. Then the next thing I would want to do is check atlas. I do where I can face you here. I'm just going to go any motion palpation, x-ray, whatever you find, but normally the side of major subluxation is going to be stuck like he's stuck on the right. Moving free on the right, but he's stuck here on the left. Was he going this way is okay, there, like that's going to be. So I'm going to adjust with Skinny Mini, right, the Atlas Pro, and I come right straight into the Atlas. I just slide up the master where the Atlas is. There's the Atlas transverse right here. On the right side, I just slide down off the masculine, right onto the atlas here. Then I open up the articulation a little bit, just like Gonstead. This is a Gonstead move. I learned this from Gonstead. But if you're a Gonstead, you do this about 5 or 6 years, you have carpal tunnel, your neck hurts and everything else, because you're thrusting like this, and you're in an awkward position. So I took everything I learned from Gonstead, I transferred it to the instrument. I have the atlas right here, open the articulation up. I'm just going to shoot straight across. Now here's the key. Is it atlas anterior or posterior? Well, if you have x-rays, you know. But if you don't have x-rays, the body will tell you. That's what we want to really get into this weekend. So I just, how much do you open it up? Right here, his muscles are kind of tense. I go here, oh, they relax. I go past that point, right there, they lock up again, so I go right in the middle. Same way here. If I go this way, well, right there, he locks up like crazy. I go here, he opens up. If I go this way here, he's tight all the rest of it. So I come right back, oh, he opens up and relaxes. Give him a love tap. Got it? Now when I come back and check that, oh, wow. It's so cool. He's just moving real good and easy. If I had x-rays, if you're an upper cervical person, you could find the correction and do it that way. But this palpation way is very great.
So it looks like you open the articulation to correct by finding the couple movement of lateral flexion rotation.
Yeah, it's just like that. Did you ever take Gonstead? Okay, so you open up the, if it's an ASL, it's come left, I open the articulation to the right, because the way the condyles sit on the atlas, I'm going to slide them up. So if I open this up here, and I'm going to slide across, right straight across. And you'll feel it slide right, just like you did with the thumb move. The problem with the thumb move, and Troxel is the one who taught me when I was in chiropractic school. And right when I was in chiropractic school, you have carpal tunnel, you had elbow problems, because you're doing this all day long, you're thrusting, and you're in a compromised position. All right, so when I open that up, that's beautiful. Now to check for a cervical disc, I come around here and I just compress it. In other words, we were taught to do a foraminal encroachment. Okay, you push down like this to see if it hurt people. But so I combined that with foraminal encroachment to see if it made muscle go weak, and it does. Now by taking the other way, foraminal encroachment, so both sides it gets weak. Well, I can be real specific and I say, geez, which side is the most important, one side or another? I could ask that by going to what's called the priority mode. I don't do a lot of hand modes, but this is the bird finger in California, and this is its nest right here in Arizona. So if I do priority and I touch this side, hold tight for me, he doesn't get weak. If I touch this side, he gets weaker, so the body, so this is a priority side.
I thought 2 negatives was a positive.
Say it again?
I thought 2 negatives was a positive. So
Well, but he's only weak when I do this. I mean, don't do that by just checking. It's not a negative, it's positive. It's okay. He's strong. He's strong here, and he's strong here. He only gets weak when I touch the priority mode. He doesn't get weak over here. But you're right. If he was into weakness, and I did something else that was weak, that'd be strong. Are you confused or not? You okay?
When you tilted him left, he was weak. You tilted him right, he was weak. You said he's got it on both sides, so let's ask priority. So then when you ask priority, he remained weak on the side that's priority.
Okay, listen through, because I said it correct. Listen. Hold tight here. If I just palpate him, he says, I don't have a problem. He has no problem in his neck. I just asked him, is there a problem in his neck? No. I said, but under pressure, is there a problem? Yes. On that side? Is there a problem over on this side? Yes, there is. Now, I don't know which one's priority. Maybe it doesn't make a difference. But now he's back to strong again. So if I touch priority here, is this side the priority? It says no. Is this side the priority? It gets weak. It says yes.
You don't have to do the compression portion of it? Because when you asked in the clear, it said no. Then you do the compression, it said yes. But now you're not asking compression anymore, you're asking the clear.
I know, but he's a computer, isn't he? So what I had up on the screen last is what you're seeing.
Okay.
Okay?
Okay.
Until I do something different, his body's still thinking about what I did the last time. I just said, do you have a pressure in this disc? Yes. And this disc? Yes. Okay, he's thinking disc. I'm saying, is this the major? No. Is this a major? Yes. Great question. Deep question. Nobody ever asked that.
So you didn't get, sorry, so he got strong on, no, he got weak on the side of priority.
Sure, because that's the question I asked. I said, I found out he was weak, but I had to challenge him. He said, I don't have a neck problem yet. He just fixed it. I said, but if he goes under stress, you have, oh yeah, I have a problem there. Oh, okay, that's a different question. I say, okay, well, which side's the priority? It is, the answer, the yes answer is always gonna be when it goes from what it is to something different. In other words, if you're weak and you go strong, that's yes. If you're strong and go weak, that's yes. So I said, is this the problem? It says, nope. Is this the problem? Yep. Okay, you're still a little foggy, but
I'm not.
okay, it's like, I'm on the computer right here, and I have this program up. It's called Certification August 2012. As long as I stay on that program, I can go onto any one of the slides. If I go out of that program into Certification 2011, they don't say the same thing. I can get the same answer. Anything I ask his body, whatever I ask right then, if I don't ask a different question, he's in that computer mode. I'm asking, do you have a cervical disc? Yes. Where? Here and here. Which is priority? Not this one, that one.
What if you compressed him on this side with priority, you compressed him there, and you compressed him there, saying, I'm still asking that question?
It might do that, but I've never done it. That's like, that is asking two questions at once, and I might not know what the right answer is. I mean, I can do it for you and see. Let's do compression here. Hold. It worked that time. So we may have, that may be
So
the
he
answer.
got strong on the side of priority.
It stayed strong and didn't go weak on the side of non-priority. In other words, this, I said here, I want priority only. Is the priority, if you have a disc over here and is a priority? It says no. I said, do you have a disc over here and is a priority? It says yes. Why wouldn't I want to do that? Because I really want to know if he has a disc, period. Because when I correct this one may not correct. I want to say, do you have a disc on either side? It says yes, I have one on both sides. Which one do I want to fix first? This one.
I thought that because when you compress him, he's in a state of weakness, that's what we discovered, he's got disc on both sides. So then when you ask the question, he'll go strong, meaning that's the side, 2 negatives equal to positive. I thought that's what
But no, because I went back to neutral again. It wasn't in the weakness. If it stayed in the weakness, you're right. In other words, he isn't weak anymore.
when you tilt
He's
the
only
compress-
weak when I do this.
Yeah.
Okay, when I go back to here, he's not in a weakness anymore.
But when you compress them and you're asking priority, he's in weakness because you're compressing him.
Yeah, but when I asked the question, I didn't go back into weakness. I stayed into strength. I leave him into strength. Are you having a problem here? No. Here, no. Here, no. Here, yes. Depends on the way you ask the question. See, if I had gone like this and made him weak, and then gone into mode and he goes strong,
Yes.
then that would
That's
be
the side of priority.
side of priority.
So I-
Same question, just asked in a different way. I've always just done it this way because, let me show you why. I now, I'm gonna go to Fat Albert, I don't want the Atlas probe on there. And I see it. If you can't see it, you need to feel it. We're gonna practice on seeing it later, hold tight. But I just say, is it here? No. Is it here? Yep, it's right there. Well, I don't want to pound into the sternocleidomastoides muscle, that's a big old muscle, so I pull it slightly out of my way. Well, how do you know this is the right technique? Because I invented it. A lot of people have stolen it, my freaking technique. Because the people that have stolen it, some of them, once they find it, they turn it away 10 degrees, because they didn't listen close enough, and do that, and feel the, go, ah! The sternocleidomastoid tightens up. So when I put it on here, you're neutral. You want to turn your head either way. I slide the Fat Albert right on that. Now I turn it 10 degrees only to, and oh, it says thank you. Give it a left tap, just like that. Now some of the guys are out here on the dadgum cartilage. You can kill you. They're right on the muscle and it hurts like crazy. Now I tap the muscle and say, are you sure that's everything? Because when you tap it, if anything hidden will come up. I can come and check him now. He's strong. I go and check him now. He's strong. I got a home run. One correction did both of them. But a lot of times you correct that one and the body say, thanks, but now I've got this one too. So in his case, we know it's just one and done.
So you tap to ask if there's anything else in there.
Yeah, I say, you tap it, you say, you sure there's nothing else in there? He says, no, I'm fine with it. Okay, now I have a question.
Yeah, so you had, when you were standing on this side, you checked him in the neutral, he was fine. You challenged that by compressing with lateral flexion. You saw that there's weakness, so then you went in to find that it was on both sides, you went to priority. Could you have just at the beginning come out with the subluxation mode and he would have tested?
It's not a subluxation, it's a disc. No, it wouldn't come, it doesn't show. It's not a
Wouldn't show.
subluxation. Right. And here, and because, I mean, that's why I'm trained. I'm Gonstead trained, right? I understand that. And we're very, very good at it. I went to Mount Orb and did did a lot of study up there, but then I did AK, I found problems there, and I took motion palpation, now I learned how to merge it all together. And why I came up with this concept is my orthopedic class. This is shoulder compression, right? You see if is there any pain there, we just recorded that, go, yeah. Or you do fractional compression, so it's your shoulder stretch, you're there, and either one, you record it. They never told you how to fix it, you just document there's a disc problem. I said, screw that, let's find the problem and fix it. So I merged those together by doing them and testing the muscle. Now we corrected it, man, we just, and of course, you use specific nutrition. There's a DJD factor from Zymogen, just that's the nutrition, it just locks it in place real good. So that's pretty much the way you do a cervical and thoracic area.
And do you self-test, I mean, just from a speed of efficiency and all that, I mean, just.
Yeah, could you just self-test? I could just see it. The reason I don't just do that is for his benefit. I want him to see you're pretty good shape. When I do this though, you go, wait, gosh, he says, in his mind says, what is that? That means the disc itself is swollen. When I go like that, you have a swollen area in there. Okay, so when I correct that and I do it again, they know I found it, nobody else ever found it, and I fixed it. In their mind, they say I'm a genius. And I said, you're right. I am a genius. You know, how did I see 50 to 70 new patients a month? Because when I'm with this patient, I'm with this patient. And a lot of stuff I do is for their benefit, not mine. I want them to feel it, them to see it, and them to say, wow. I want them to say, wow, 3 visits, 3 times each visit. I want them to see that, wow, this guy really found something nobody else found. Rather than just the symptoms go away, that's cool. I want the symptoms to go away, but they know why. I know why it went away, and I tell them why it went away. And I'd even show them, I have the DJD nutrients, I have both these in, and making even before I adjust it goes away. Well, if I can make it go away with the adjustment, I can make it go with the nutrition. How do you know which one to do? Both. Because I correct it structurally and I reward it nutritionally. Now it's like we'll be readjusting 3 times a day with the nutrition. Very, very important. That's why I sold $300,000 a month of nutrition. Not because I needed the income. It's never bad. They needed it, but they got better and stayed better and preferred their friends, right? How much advertising you do in the newspaper? What's a newspaper? What times do you read that? You know, the bad news. You don't, because the patients get better. And that's why they know why, you know why. It's like if you shoot pull and you just shoot hard and holler, sometimes the ball goes in. But you don't know which pocket or how often it's going to happen. But if you can say that ball in that pocket, you put it in there, that's pretty impressive pull shooting. And that's what we're doing here. And you've got to understand the placebo effect. And they always made the placebo effect sound like something that was bad behind your back. Like, but the placebo effect is great. But I'm not causing a placebo effect, but I'm causing a greater than the placebo effect. I'm causing something where I see the problem, I show them the problem, but then we call the shot, and then we fix the problem. So what you're getting now is positive reinforcement. It's like a placebo effect, but way beyond placebo. It's like knowing this. Oh my gosh, he sees the problem. We find it. We fix it together. I get better. I want my wife, my mom, my brother, my cousin, my neighbor to get to see this guy. Does that make sense? A lot of practice is psychological. And you think, Dr. Jesse's short and has curly hair and he's from Jersey. Talks funny. He's going to do $1.5 million this year? How do you do that? Because he owns what he does. He knows that he knows. And when you know that you know, and the patient knows you know, it's all over, you know. I've been saying that for a lot of years. But what you project to that patient, what the patient receives and projects back to you in the universe, that's your life. What do you want out of your life? I want to know that I know. And if I don't know it, I want to find it out. And I want to fix it. I want to know that it's fixed. I want them to know it's fixed. I want them to know it's us that fixed it together. And that what I say is going to be reality. And if something breaks that down, we got to figure out why. Why did he get better today, and then 6 months later it's not better anymore? He quit coming in, he quit taking his nutrition. One of the 6 interferences popped up. Oh, he just went through a divorce. That'll do it. So everything that happens, it happens for a reason. This universe, it is random. It's quantum and quantum physics, but there is an organized fashion in the way it happens. And the more we can see how it fits in the 6 interferences, that was structural. The designers and guys are not used to seeing things this way. So they said, gosh, tell us when you just fix something. Did you fix that nutritionally, emotionally, or structurally? And that was structural. But could there be an emotional component to his neck? Sure, sit back up a minute. So the other thing that we could do here is we could literally challenge a nutritional action too. So I could do this by doing hold, and I could just stretch the joint, and if he gets weak, I know his neck is not gonna hold. As soon as he walks across, just get it, run down there and back again. Okay, just have a chair. When I come back and check him now, guess what's gonna happen? Even the disc that didn't show up the second time is back. But if I give him max adrenal and do that, it doesn't. Okay, run up back again now, hold the max adrenal hand. And how is max adrenal different than DSF? Everything is activated in it. When I check him now, okay, so he now sees not only do I need to adjust him occasionally, he needs to take his max adrenal every day, so what do we do? Corrects. Fair enough? Well, that's cool. Now, there's two things we need to do for this problem. Now, feeling he's buried alive book, did we get up here with him? Solitaire? I think if you can bring me one, it'd be great. Well, I've got one here. Okay, the other thing I could check for him now is, if we check his neck now, hold tight for me, a little hard. He says, I don't have a neck problem anymore, thanks a lot, you're a great doc. But I can go into the book and I can go under neck problems. And I believe it's actually under back problems upper. What this is. Remember if it says neck by itself? It does not? It does, okay. So this is towards the back of the book. And it is neck problems. So certain emotions can trigger issues. So let's just think of moving under pressure. But what you do is just pressure from every direction you come, cause your neck to be out. Oh, we have a problem with emotions too. Want to let feelings out, but don't dare. It's not very male of you. He wants to let feelings out, but he doesn't dare let them out. Okay. Oh, yeah, just tap, and he should, the best way is tap them, actually tap them right over your thymus. So the thymus tap more, heart, thymus, it's all good, the whole area left or center. And then, here's one I'm sure a male would never have, inflexible state of mind. Inflexible state of mind. Okay, so you have that too. I know, you really started that one. The other one is not wanting to yield to her opinion, not wanting to yield to her opinion. I mean, I can be her up. Oh, that's not a problem. It really says not wanting to yield to opinions you think are wrong. Yielding. That's different. That's a different statement, isn't it? Not wanting to yield to her opinion, not wanting to yield to opinions wrong. Well, I don't want to yield to opinions wrong either. But it shouldn't blow us weak. It should just say, yeah, I'm going to hold on to that. Non-acceptance and rejection of others. So some kind of a non-acceptance or rejection of others. Others male, others female. Okay, maybe male versus female. Okay, now you could actually say, when did this problem with your neck come emotionally? Just hold tight here and let me go down. You don't have to tap for me. I'll just do it without any tap. We can infer that. When did this come? Did this come when you were still in the womb? Oh, still, you ain't born yet. This has happened. Did it happen mainly feelings you're picking up from your father or your mother? Father. In the womb, his father. See, dads are a pain in the butt no matter even before we're born. These guys cause this problem. All right. And then, did this affect you periodically throughout? Let's see, in the first 5 years of life, other than born. First, between 5 and 10. Between 10 and 15. See, this is an issue. And is it male or female? How are you and your dad? Was there acceptance?
He actually dropped me off at the airport, yeah, so it's...
So right now you guys are pretty good friends?
I mean, not really, no. It's not like there's anything wrong, but there's definitely no connection.
Okay. Is that what you would have gathered from that too? I mean, that's what I would have got. Somehow, even from, and we could even go into there, what was happening between his mom and his dad when he was in the womb? I'd say there was conflict
They're
there.
actually dealing with that now, and it's funny, it's recently she's spurred up.
See, that's big conflict. And that's affecting his neck now when he's, how old?
27.
27? Now, for 27 plus years, yeah, that's how long it bothers you. Forever, till you solve it. Is there any alcohol in the family? Or addiction?
There's definitely addictions.
Okay.
Sure.
Read Bradshaw and the family talking about addictions. you think you're your own boss, you ain't your own boss, you're a friggin' puppet on the string. You meaning the guy looking back in the mirror at me. We're programmed, gang, and so the only way you get unprogrammed is to release all the stuff that's in there. So, that's good. Are we having fun yet? Oh, good. You want to shine down his heart for us, if you would? Heart and brainstem, because John Bradshaw on the family. That's one of them. So the best thing is hair, frontal, over the frontal lobe of the brain, brainstem and heart. Okay? Let's just see if all that's doing now. And he's holding his hair at capitulin, and if you want to tie in all the bladder brain, you can go here and here. Now you're tying in all the acupuncture brains to the bladder, and the brain through here, at the same time you're lasering here and here. So it's list different ways of doing it. Now, since we're on this, another thing that we could do, if we did, say we didn't have a laser, heaven forbid, I could just have him look his eyes straight to the right, eyes straight to the left, and when he looks straight to the left, he goes weak. So that tells me that's the part of the brain this emotion has been stored in his whole life. So I can have him do this. Look all the way here, all the way here, all the way over here. I take it back. It's like taking the saw and sawing away that emotion's been doing me forever.
Did you start on the side that it was at?
Doesn't matter.
Doesn't matter.
No, you just keep going. Okay. You just sawing it away. Who dreamed this up? I did. So look this way. Now turn the eyes there. Okay. Look up. Look down. Okay. So I don't find anywhere else. If we go back and read these now, like we did before, inflexible state of mind, not wanting to deal with the opinion you think are wrong, non-acceptance or rejection of others, you stay good and strong. Moving under pressure, wanting to let feelings out but don't dare. All those are now strong that we're weak a minute ago. Is that gone forever? Well, the layer we're on right now, and we're at a deeper level we've ever been before because we brought up it happened in the womb. It happened up through all periods of his life. It definitely ties into his father, a feeling of non-acceptance, and disharmony between his mom and his dad. We tapped all that in and lasered it out. It's gone. It's just like where'd it go? Well, you type something on the computer, you put erase, and you erase it off the hard drive, it's gone. Where'd it go? Well, energy is neither created or destroyed, it just changes form. So you change that form where it's no longer an emotion hanging on to him, giving him a pain in the neck. You dissipated it because you became aware of it, just let it go. Are there other issues with him, his father, his mother, and father? Sure there are. We'll bring them up later and solve them. But for now, his neck's going to be better, it's been forever.
Question. So, just like when you tested my neck and then you found that the emotion was another part, like could a food trigger it? Because I look at it like the intuition behind that is food. And I notice that sometimes, a great deal of time, that I have that same, like toward the end of the night. So if I eat a certain food or just eat late night in general, would that trigger that same sort of kind of cascade, the emotion leading to the subluxation or the...
Of course it could. All 6 interferences, I only addressed 3. Structure, emotion, nutrition. But now we have potential food allergies and addiction. That's why the allergy machine comes in there. I'm not selling anything other than think of the concept. We've been doing manual muscle testing for the allergies all these years, and I love it, but there's a couple things about it I haven't ever liked. One is putting the friggin' vials on. The hardest part of the technique is putting them away. I hate that. And the other part is you are isolating the allergy part. Where when you do the machine, what's the major thing every time? Every one of the 12 major areas shows up. All the emotions related to that. So what I do now is I say, I think there's some allergic component to that with what you just told me. Let's schedule you for some allergy work. I mean, it's a separate fee, but trust me, if you really like to get better with this, I think you should go the entire 12 series and talk to the girls about, I don't have time to talk about price or anything. Talk to them and set this up, because I think it'd be a really good time to do that, and let's clear this thing out. So now when they go back and they check you, they find out which foods he's reacting to after we've just done this correction, and which emotions tie into it. And not only does it figure out which emotions are tied into it, it figures out which homeopathic remedies to give you and the potency. So when you do does everybody understand homeopathy here? Anybody not understand homeopathy and potency? Great, great. When I did the Zymogen meeting, another thing about Zymogen is so different from where I've been before. Before, the only time you ever talk to anybody, you have an isolated idea, and most of the time they say it's too expensive, we don't want to do it. Where with Zymogen, you meet twice a year. They pay for everybody to fly wherever you are. We just got back from Canada. 25 people they pay to be there, and all 25 of you rip each other apart for 2 days solid about your belief systems and what it is and why you need it and what's in it and why is the product better and why is the name better, do you need anything changed? And I say that kind of gently, but I mean, everyone's nice to each other. And when they had me introduce the Brimhall Bioinjection line for Zymogen, the one guy there's a researcher. He's a member of the board. He's not a member of Zymogen, other than he's strictly a paid researcher to prove points or disprove points. And when I told him about homeopathics and the homeopathic lead and iron, his eyes rolled up. I saw nothing but white for 2 minutes. I thought he died. And I said, okay, time out, Joe. Where'd you go? You're giving people iron or lead or aluminum? And so I had to stop him saying, okay, they're diluted doses. So the way I explain to patients is a homeopathic is like you have a problem. With this problem, let's say your problem is crying, your eyes tear all the time. You go back in the world and you say, okay, what vegetable or natural substance would make my eyes tear? Oh, onions. Well, if you take pure onion juice and you put it in your eyes, heaven forbid, you scream bloody murder. But what if you took onion juice and you diluted it down 6 times, 12 times, 100 times, 1,000 times, 1,000,000 times? One of those dilutions in there would make all, if you took it under the tongue, the body said, oh, I have a problem with bottom eye, and you'd stop. That's homeopathy. So when you figure homeopathy, even with a repertoire, it can take hours. The book, you look at everything, this symptom, that thing. But with a computer, it evaluates your energy field, puts it into the system says, hey, you got crying eyes, you need 6x 12 hours, 1C3M, and homeopathically, you need horsehair. And so it makes all that for you, and when you laser it back into the body, and then you send that home with them, you're wearing it all the rest of the week or 2 weeks, producers to do it again, you desensitized it, you took care of the emotion, and you gave you a homeopathic remedy all at the same time. That's cool, and that's why I like it. So we did structure, nutrition, emotion. What about allergy? We just addressed how we do allergies. Well, what about the other one? What about toxins? Well, I would check toxins with the metals and the allergens next time he comes in, or I might make very specific recommendations of all the nutritional profile. Let's check the next time he comes to do a scan on that. Fair enough? I'll do that. Thank you. Sure. So we did the cervical, longest demonstration ever taken. The next thing I want to know is, I learned in AK that the facets, and those are the posterior mechanical facets that come together between vertebrae, have massive nerves. I mean, the disc has a little bit of nerve supply, but these guys are loaded. So if they get jammed, twisted, it's painful. So we want to check that. And the way we were taught to do it is to check any muscle here, pull toes in, and we check the low back muscles, and we just stretch the facets like this and recheck it. And it said, he's okay. I just pull it like this and check it because it's faster. It pulls it down here and it's faster. If for any reason that got weak when I pulled it down, I would take Fat Albert here and I would just go obliquely across the abdominal muscles this way and this way. This way and this way. Look like this. And that frees up those facets without me jerking on it, because the correction AK-wise is you put a block into the back here, you slide under here and here, and then you would take the leg here and you would rotate the toes in so it kind of locks the knee in place. He's already had knee surgery, I don't want to damage it. I go with my hands above the knee so I don't damage the joint. I get a sharp quick thrust like that and it frees up the facets. I run with the instruments just as fast, much faster and easier on me.
Okay, no, I thought the adjustment was on the cassette with down and out, up and out.
It is, exactly, but what we found in some cases, if you just go contour both ways like this on all 4, if it's on this side, you just go this way and this way, we found it releases the muscle a little bit better. Some new things we've learned just the last few years. Your way's been working that we taught originally, but we found this sometimes even coming across the other way can help it more.
So do you localize to see exactly which level or shape?
You can if you want to, but it's a waste of time, unless it keeps recurring.
Because you're not going to get all 5 of them just doing what you're doing, are you?
It does.
Oh, okay.
It gets all 5 of them because when you're going like that contralateral and this way, it's like the body's going there, sending the message that all those muscles relax and the facets turn loose. Exactly why, I don't know, but it's working really well, other than you're sending that impulse in there and the body's relaxing. Now,
So
to check,
again, you're going from
You're just gonna obliquely
Lateral
through
to
it.
medial, both sides up and down.
Right,
Okay.
yeah, that's the cheaper way we developed the last couple of years, because a couple of docs showed me, well, that's great, but sometimes I found it hasn't worked as well if I come contralateral, because now you're sending the message all the way across, it's just a good, easy way to do it.
So you're just doing 4 points, or you're doing more?
Pretty much 4 points.
4 points.
Yeah, I come in there, it looks kind of like this. And you see, you're releasing intestines too, you're doing a lot of good stuff, you're releasing the iliopsoas muscle, just all good stuff. Disc-wise, though, is different, so we stretch it for imbrication. For a disc, you just jam it, like you jam the neck here. Again, we found if we jam it down here and it goes weak, then we have a disc problem. Not on this side, but on this one. Now I will identify exactly which one it is. Is it 5-on-S1? Nope. Is it 4-on-5? In his case, it is. So I keep my hand there, bend the knee on this side, and here's the belly button, I'm slightly lateral. I don't want to be right over the center because the abdominal aorta comes down there. So I come lateral and I angle it back towards the center of the spine. I pull the trigger and I come down, I just pull it real soft, and you'll hear the resistance right there. You hear the resistance? And there it goes, it'll fall through. You'll hear it going, and then it'll just soften right on through. If you listen and feel it, you'll feel the resistance and then go on through there. Come back and check it now, and jam it, no more problem. Again, the nutrition would be DJD factors. That's it, that's the main thing. Anterior thoracic, patients get them, and we used to do a lot of this stuff here. When you go over here and put your hand in and crunch, crunch, crunch. It kind of gets weared on you after 20, 30 years, particularly if your foot motorcycles in over in, like I did, ripping all loose. So I learned to do it here. I can just come like this. Okay.
Are you midline?
Midline, right smack dab in the center. Absolutely. Now there is something that comes up in the manual. All this is in the manual. The pictures are in the manual, 100%. You don't have to guess what we're thinking about this. But just lately, I had one of the board members call me, and they called me as an expert witness, and they said, where do you teach the doctors they can put the percussor in the adjuster? And I said, well, they can put anywhere, except we always tell them, never percuss or use the adjuster over the testicles because it's painful, and not the breast tissue. Well, this guy was using it over the breast tissue, and it had a complaint file. He said, I know, I was at your seminar, I heard that, I went to your manual and I found that, but we need to testify to that, because he said you taught him that you percuss the breast tissue. Don't do it. Stay away from very delicate areas, and you do percuss the symphysis pubis, but be very careful where you put your hands, and if you're a guy, have a lady in the room if you're going to do it. And I would explain to I never had anybody ever complain or anything like that, because my mind is exactly where it belongs in that circumstance. But two, I would just have the patient, I want you to come down here and feel there's kind of a bony prominence in there. You feel the bone right there? That's called the symphysis pubis. On a lady, and when you have childbirth, a lot of times they'll come crooked like this. I think that bladder linkage you have is coming from there. We're going to go ahead and put that percussor on and realign that. Does that make sense to you guys? Okay, then you do it. And you percuss it. Never breast tissue, never towards the female area there. You're asking for a problem you can't get out of. I also had the board member call me one time, and they said, what do you tell your doctors about treating cancer? I said, we tell them, we treat people that have cancer. We definitely don't treat cancer to have people. You heard me say it many times in different ways. My license, I don't think any chiropractic license allows you to treat cancer, but certainly we want to treat people that have cancer. We just don't treat the cancer. He said, I know, I was your son. See, also a board member had been there. He said, I heard you say that as well. This guy treated cancer, so you tell him how to treat cancer. Yeah. But have you treated people with cancer, went into remission? That happens a lot. In fact, when it doesn't, I'm very disappointed. I did treat the cancer. I just treated the body to be as well as could possibly be, no matter what they had. If they get over the cancer, that's spontaneous remission. It's not my fault. Yes, sir.
So when you say you can't percuss that breast tissue, that doesn't exclude like pectoralis major, like
No.
up here, like in like lymph ducts, just not actual.
Yeah, just not the breast tissue itself.
Okay.
Now, I would tell a lady sometimes, I treat a lot of people with fibrocystic breast disease and all kinds of lymphatic congestion and everything else. And I would say, look, take their hands. Your breast is areolar tissue is full of ducts. Why don't you take and massage your breast? And I take their hand, go this way, then this way with lotion, and this way with this way. And then when I touch them, no, I didn't. Did I show them how to help themselves? Yes. That I've done. Never percuss breast tissue. What's something else you never percuss? Eyes. Yeah, it wouldn't go around the eye. What if they had a detached retina, which you can go around the cranium? Nowhere on the cranium with a detached retina. What about if there's been a surgery and there's wire or clips in there? Would you go right over the wire or clips? No, we had one doctor that did. He got gangrene and they had to amputate a lady's leg. It was wire in it from an old surgery. So there's just certain things. Play the game. There's the contraindications there. And on the exam it says it's a contraindication for percussion. So please refer to it.
Like those open heart surgeries where they twine the sternum together.
You gotta really be careful. I have done those, but I come to the side, I put some cloth over the top of it, I've maybe gone through the mat, but be real careful. On the old, I don't think they do that on the new surgeries, a lot of old surgeries have those a lot.
You can percuss safely on the back.
Oh, anywhere on the back, sure, but, you know, sometimes you'll have a fusion, like, what about heritage rod fusion and things like that? I've still done it very careful, very, very careful.
Hip replacements, the hip stuff, you know.
Yeah, and sometimes your contact is right on the metal, and you'll find it just like that. I mean, it just changes so quick. So you say, look, I'm being very gentle. I know you had the surgery there. This will relax the fascia and the scar tissue from when they had the surgery, and just feel it. But because this bone is living material, it's really kind of soft. You can compare it. But if you come in here and you percuss it, and your listing hand's on there, and you're on a hip replacement or a metal part in there, you'll feel it change so fast because you're going against the nose. It just flips. And if you're there more than 3 or 4 seconds, you're there too long. You're just not feeling what's going on. All right, so that's basically the adjuster for the arthrostim. Again, 2 different companies, same technique. Next thing, let's go to the percussor or vibrocussor, both of them work well, and manufactured from different companies. This is designed to be a human jackhammer. It's about the only way I can describe it to you. If you're gonna, I was raised in the construction world, so you use a cement finisher, goes round and round, helps you finish the cement, or sanders where you sand stuff off. If you want to break concrete down, what do you use? A jackhammer. And what are you doing? You're going in there so hard and fast, you're hitting the bonds of concrete until they get so much vibration they crack. Well, that's what a percussor is. It's a human jackhammer. When I do this, it is an up and down, not a vibratory, not a side to side, it's up and down. So when I take this, I want to put it on a bony prominence and release the muscles anywhere that attaches there. So let's say I want to release the whole leg. To release the whole leg, I would come in here on the femoral head. On this femoral head, I'm going to put the percussion hammer. Here we go, like this. And when I do that, I'm going to feel the vibration come through the other side completely. Now, if I went in the knee joint, I could cause damage. Keep out of the friggin' joint. You go above or below the joint on a bony prominence. So my listing hand is always opposite, if at all possible. I come on the closest bony joint to where I want it moved. And then we're causing a war in there. All the tissues tightening up. Why are they tightening up? Because I'm jackhammering it. But instead of just letting it crack anywhere, my listening hand is on the opposite side and is holding all of that pressure put in there. So if I have, let's say I had a surgery in my pant leg, and there's a restriction right here. To free up the restriction, I put the percussor here, my listening hand here, which winds the tissue up more and more and more to where it no longer can be held back, and then it all rolls out at one time. That's why you feel the release. Does that make sense to everybody? The fascia surrounds everywhere. That's just completely enveloped. But any scar tissue anywhere causes restriction and pulling everywhere. So if my shirt is screwed into my skin right here, my body moves around that constantly. It can't do anything because it's constantly moving around there. I can't go this way because it got it. I can't go this way because it got it. I can't go this. So all the rhythm of the body is moving constantly, pivots around that scar tissue. For us to free up the scar tissue is like a miracle of miracles. And the contact points are in the book. Look into your book under structure, please. Going to structure and percussion.
That's how I started as a patient because of my life.
Yeah, because that's surgery. A life changer, right?
Yeah.
So now, if we want to free it up, turn to the picture. The percussion starts on page 9, and if you'll go a few, there has all the verbiage there, explains to you step by step what I just went over there. And then put over in like 18, 19, it's actually showing you, it's taking all the different areas and categories and what they look like and where your contact point is, and all that stuff is there visible for you, okay? But let's just make it real simple. If I'm going to release somebody and I'm gonna start on the first time, like a baby, I'm always gonna start on fibula head. Why? Because the fibula head on the left side is always like this over the ankle. If you look at many, many infants and babies, it's right here like this. So what you have to do is you unwind that, cause a universal cranial fall. So I know this is the right side, but it's the left side. I'm gonna come right here on the proximal fibula head. Proximal means closest to the head. On the proximal fibula head, the center of the plunger is gonna go right on that proximal fibula head. My listening hand's gonna come across, and I'm gonna wind it up until you feel it tight, and then it's gonna occur. It's gonna release. Then if I want to do the opposite leg, I go to the other proximal fibula head. If I want to stay on this leg, I come down to the distal fibula head. I can even come to the inside of the femur here, and my listening hand would go over here. If I'm going to release the whole pelvis, my percussor is going to come on the greater trochanter. Okay, here's your femur head up through here, and there's your head, the trochanteric head. It kind of looks like that. It's kind of on an angle, and then the ball goes right into the ball and socket there. And my son, the evil one, the surgeon, is replacing hips and shoulders and joints and all the guys I went to high school with. They don't do what I do, right? Even fraction, I'm still running up and down hills. Those guys are in surgery having hips replaced. What's the difference? Nutrition, exercise, all 6 interferences. Work to try to keep those balanced as much as you can all the time. I think these, come on, what about 100 years ago, did they do hip replacements? I don't think so. They didn't need to because people got more exercise, they ate better, they exercised constantly. But right now, people are sitting in front of computer chairs and not getting enough exercise. But you percuss that greater trochanter, your listening hand comes over on this side. And it unwinds the whole pelvis at one time. You'll feel it tighten, 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 and you'll feel it unwind. You only have to do the right greater trochanter, it releases the whole pelvis. Because the left greater trochanter is not necessary from the right side, the whole thing will release. So there's a few rights that I want you to think about. You only have to release the right greater trochanter to release the hip. You always, if you're going to percuss the shoulder, you always start on the right shoulder. And when you release, do shock release, you're always on the right side of men, because men are always right. You got that? There's really not any lefts I can think of other than you stand on the left side of ladies, and so let's talk about shock release. If he were a she, and it doesn't matter about the practitioner, but the patient, it's just the energy field is better protected if you go beneath the xiphoid, between the xiphoid and belly button, shock release. I come right down in here, I go straight down in until I feel a wall, and then as it starts to release, I go down deeper and deeper until it completely releases. Now be very careful. You need to have this done to you before you do it to anybody else, because it works like crazy. You need to know that, but boy, it releases emotion. It's almost like a rebirthing process. It releases emotion all the way back from conception to present time. So you tell people, hey, you can wind up crying the next 24 hours. So let me recap what I said a minute ago. I'm only going to do the right greater trochanter. When I percuss the rib cage, I'm only going to do the right, because why can I release the rib cage here on the right? What's there? The liver, which is the largest organ by weight in the body. If I come over to the left side and do it, I could lock the liver up, and I could crack a rib, particularly on an older person or younger person. So I come on the right side with my listening hand on the left. The reason I always percuss the right shoulder first, you sit on your hands, you turn your palm side up and have them sit on their hands, and you bring the percussor head right into here. There's what's called the deltoid recess. See it here? He lifts weights here, big strong dude. Come right here, there's a negative kind of a hole right there. That's where the percussor head goes. And your listening hand can go all the way over on the other side, or it can go into the occiput. Because when you percuss the right shoulder, it actually releases all the muscles all the way through the rib cage, all the way up to the occiput. When you come on the left side at that deltoid recess, and you percussion here, releases all the musculature in the lungs and the thyroid and the heart, put up to the frontal bone. So you always want to bring the occiput posterior before you release the frontal bone, or it can cause a headache. So we do a right greater trochanter, right rib cage, right shoulder first. What about TMJ? Did it have a right or left?
Yes,
Pardon?
why not?
It's not necessary to go right or left, it's whatever the one the body tells you, but you'll find right more often because of right-handed people, I think. I find a lot more rights than I do left, but it doesn't have to be right. But shock release, you always relieve ladies from the left, guys from the right, and you can use the percussor as well. That's my technique, not Fulford's. The other techniques I'm giving you, I learned from Robert Fulford, osteopath. You come beneath the xiphoid, come down here, I always go lateral here.
Setting anything, maybe
Say again?
setting.
Well, I do everything 7 or 8 and down to 4.
Do you just test these, I mean,
I-
they usually just test.
Let me tell you what Fulford really did. Fulford had the old Fordham unit, and it was like, it sounded like airplanes flying around there. They had a cord, and they weren't near as good or powerful as these. But what he would do is he would turn it on, and he would put it over the tissue he's gonna treat. He never did that, he always did it by hand. But let's say I'm gonna do the greater trochanter. He would just turn it here until he felt it. Right there is a great, you'll feel when the energy is the most sync with the patient. But teaching that to chiropractors, I learned really quick, it's way too complicated. So if it's the head or the arse, any tailbone or head or jaw, anything here, there or here, do 4. Everything else do 7 or 8. That way it's simple. If you're really good at feeling it, you'll feel it slightly needs to be tweaked a little bit. And every one of these has a little different personality. Like for some of these, 4 is a little too much on the jaw, and sometimes they have to go down to 3. Just any motor you make is going to have a slight different tweak to it. But I basically either do 8, 7, 8, or 4, about everywhere.
One last question today. What happens if a female diastasis recti musculature, separation from pregnancy or whatever?
Right.
What's any different protocol? Would
Just
kinda
be
go
careful.
in?
Just be careful with that because they're pretty weak and stuff in there. There's some really good creams and nutrition you can use to help strengthen that up. Now, Zymogen has a product called Regenex, and it regenerates the tissue. Now, they really are doing a lot of studies to show that it is like a nutritional facelift. They don't dare say that in print, but some of the people who've been on it for a while are seeing a definite change called Regenex. So I would have them take a minimum of 1 twice a day for life and rebuild that tissue. Of course, you could use anything with glucosamine, MSM, chondroitin sulfate, so that GJD factors would be good for that as well. And also Regenex. And Dr. Gray talked about alpha lipoic acid. They have a controlled release alpha lipoic acid. It's really phenomenal. It's really balancing blood sugars and HDLs and good that way. We'll talk about specific nutrition probably when we come back from lunch, but
Do you ever test priority at all on the number? Like do a little?
it's just too much agony for no reason.
Okay.
Yeah, it's just, there's some things that are critical and some are not, and that's a not. Just do it. And if it feels like it's too much, back it off a little bit. If it feels like not getting the job done, turn it up slightly and increase the pressure of your hand. So that's the way what about an ankle? Well, you come to the fibula head. What about the feet? You come right on the calcaneus. And I know I'm not covering this in great detail because we're going to go practice this all afternoon for the next 2 days. So we're just highlighting it, and then your instructors are going to work with you hands-on. You come up here, and you put the heel right on top of here, and you percuss into here. So when I come up here, I'm going to go right on heel, and I could just, sometimes I'll put that on the table and hold it there, and I'll just put both hands on there. So I hold that heel for a minute, and I'll do it. You'll feel it release all the way up. You can feel where the fascia is tightening, releasing, till you feel the whole head turn on. So wherever you contact the fascia, it releases all the rest of the fascia. Say it again? Sure, you can do it all. You're right on the calcaneus here, but you can do talus, you can do fibula. There's just not a contact you really can't do on the foot. Bottom of the foot is a good release like that. Really good from here. Now, he's got scar tissue on his knee, so you would never want to do the whole joint, but you could come right on the patella. You'll see a picture there. When you do a patella, your hands go underneath here, and you take the percussion right on top of the patella. And your percussion right into that patella, and you'll feel it just turn loose. I've had some horrible knee problems just straighten right out on people, or post-surgery, or think they have to have surgery, and you can prolong them a long time. If the joint's totally gone, eventually they're going to have to replace it. But that patella can stick in there. It can really get messed up on you, so by releasing that scar tissue is good. So greater trochanter, fibula, ankle, calcaneus. You say just do it in no wrong place on the feet. You can't hurt them. Right shoulder for occiput, left shoulder for frontal bone. Shock release. left on women, right on men, TMJ. These are nice. If you don't have them, you may want to get a stool like that. The office can order them from you, for you. Or you can call Ed Direct. This actually comes from Impact. On the TMJ, I like to get comfortable. I sit down. Our tables at the office come up and down this way, and the chairs, the secretary chairs come up and down too. So I want to make sure I'm comfortable. I don't want to be in an awkward position. My listening hand is going to go underneath the occiput and here just like that. So I'm feeling it. I've got it here. And the percussor is going to come right on the condyle. Now remember, most of the time when you're working on something, the center of the hammer, we call this a hammer, is going to go in the area you're working on. So if you're working on all the carpals, you just go like that. You can do posterior, or you can do anterior. In the hand, Jupitrons contractures come right on them just like this. Not a problem. Elbows, you come usually lateral like this. Listening hand here, percussion here. Unwind it. No worries. When it comes up to here though, here's your condyle, and you want to have the center of the plunger on the condyle, will give you a cauliflower ear, won't it? So what you do is you pull it over to where the tip is on the condyle, but you hold that pressure as if that's the center of your percussion. That's the only time you really have to play that game. Make sense to everybody? What about symphysis pubis? Well, the symphysis pubis, again, I'm not afraid of a guy, so I just come here and find it here. I come right over here like this. I would hold the anterior superior spine with my forearm in here. I'm going to percuss it and I'm going to release it. On the lady, I'm going to say, let's find that bone together. Just tell me when you feel that bony prominence. Okay, it's right there. All right, we're going to put this right on top of that. Now, ladies, when you do a guy, you have to be a little bit careful. When Brandy started working in chiropractic office, she's only 16 years old. She started taking my classes when she was that age. And the doctor had her percussing a guy, and she went in there percussing it. He said, Brandy, that's the best sex I'd had in 6 months. He just embarrassed her for that. She's still, well, she's 30 years old about that. But not everything was out of the way when she percussed the symphysis. So if you're a lady, you might have the guy push things out of the way. Famous joke, I'll tell him. Yeah, turn over here. So she had a lot of requests for that. Oh, thanks. Oh, that's a sexy pillow.
Yeah, I grabbed it from the room.
Exotic. Okay, Fulford always taught to do sideline percussion for the spine. Why? Because it's in its natural curves. Why? Because the listening hand can be here, and your hammer hand can be here. Now, look at where my hammer is, like this. Well, you're not level. No, I'm not level because the sacrum's not level. The sacrum's like this. So if I'm going to bring the percussion in, I'm going to be like that. I'm not going to be like this. I mean, the sacrum's like that. Does that make sense to everybody? You always keep the percussion hammer flat. So since the sacrum comes like that, I come in second sacral segment. Listening hand comes up here. I percuss into the area. When I come down the tailbone, it's going to be right where the sacrum and the coccyx meet, right there. You'll feel it. So I come right in here, down to 4 now. 8 here, 4 here. Listening hand again here. This is the lightest contact of all the contact there. Lighter than the TMJ, lighter than the cranium. Ounces. You just barely feel. Ooh, you'll feel the tissues lock. You feel when they release. We've had ladies with all kinds of emotional problems, inability to get pregnant, miscarriages, you name it, with the tailbone. And some of the authorities say a tailbone out of place can actually cause leukemia. I don't know, but I fix it. I find them, I fix it. So you percuss that and you turn it loose from there. The third lumbar is the next major point. So in other words, it's coccyx, sacrum, second sacral segment, sacral coccyx articulation down here. Third lumbar, right in the center of the spine. That's why mine is all collapsed now. Then you come up here at the major area, any thoracic area. Right up like 7th cervical, 1st thoracic, you come right in here. And again, I'm on an angle because it's on an angle there. Listening hand is right here. Well, here's a question. What about you that are non-doctors now? You can do this as well as a doctor. There's no law that says you can't release fascia. You're a craniosacral therapist, housewife, whatever. You use the adjuster, that's different. You're adjusting bones.
What indications do you have to do the tailbone, or is this just protocol for you? You just do it on everybody?
No, I definitely do it on everybody. I'm going to use it shows up. I muscle test it.
You do. Why would you muscle test it? What would you be thinking?
I check it every time on a new patient. And because when you can self-test, you just say, is there anything left in the ankle, the knees, and hip? Wow, was it sacrum? No, it was tailbone. I mean, I just I screen for it because the tailbone is the attachment of the filum terminality. That's where the fascia ends. Goodhart was really big on this. And he actually took a patient, he had him sitting, lying, and standing. He took a tapeless measure, he finds the tip of the tailbone, he touched it there, and he followed all the way out and to the EOP, the external occipital protuberance, and he would measure. He found some patients were 2 inches in length difference between sitting, lying, and standing because that filum terminality was so tight it was scrunching them down in certain positions. Then he would release them, but he didn't know about the percussor. Then I told him about the percussor. Then all the AK guys started using the percussor, and it would just release the tailbone and everything else. But it's one of my standard checks. I'm going to check for categories in the pelvis. I'm going to check for atlas, just like we check coming up. When I turn them over on their side, I'm going to check tailbone, sacral segment, third lumbar, third cervical. Those are the mains that I'm going to check. If I get a stick there, I release it. Or you can muscle test. They're going to go weak there if they have it.
So you said tailbone, third lumbar, third cervical.
No, okay, write it down. It's in your butt, but coccyx, sacral coccygeal articulation, second sacral segment, third lumbar, third cervical. Those are the most common percussion areas to release the fascia. Because the third cervical is the pivot point of all the cervical spine, third lumbar is the pivot point of the whole lumbar spine.
How about, doing with the Dowager's hump?
Oh, yeah, if you have Dowager's hump or fixation anywhere, it's great. No contraindication. Contraindication is a mass. You have a lump, even a lymphoma, keep your friggin' hands off of it.
So in the case the person that had it, C3 and then maybe C7, T1.
Sure, I always check it. And this area is so nasty, it's so hard to move, even with thumb moves or whatever. I'll percuss that area very often. Very common, particularly as people get older, locked up, they go forward, and that's a good check. Sir?
Do you always do it on the side? You never put them,
Fulford taught it on the side, but you can do it anywhere. You can do, the thing is, with the percussor, with the adjuster, they can be walking, lying, standing, sitting,
But with
on
the
their head
percussor-
upside down, the canoe doesn't matter. But the percussor, you have to be holding part somewhere, or it just does the dance. There's a guy, you know, there's a different thing. Sit up. Look, just face me this way if you don't mind, please. You can do a thing called myofascial gellosis. Goodhart and the AK guys could not feel the fascia tighten and then release. So they naturally assumed Brimhall was making this up. So they figured, what's a myofascial gellosis thing? You can take somebody that where the myofascia just gets kind of gelled instead of fluid, and all you have to do with that is just flush it with a percussor. You flush it, it goes back into motion, it's wonderful. But it doesn't free up deep fascia. Deep fascia, you have to hold it back with the listening hand and come in with the percussor like this. So to really do it well with the whole spine, you need to be sideline or face down. If he's face down, I can still do it, but the problem is, where do you put your listening hand if they're face down? So Fulford taught us to do sideline. Now in my office, I took another course from a cranial osteopath, and they did 2 percussors at once sometimes. So we developed whole two percussor techniques. We lay them face down, I have a percussor in each hand. In fact, I had 2 percussors in every room. And geez, I've never seen so many questions from veterans in their computers. All good ones. Face down for me.
Here, I have a big paper right here.
Oh, did we get them? Good. Thanks. He didn't believe in germs anyway, but we should be correct.
I brought you a big paper.
Perfect. So we have 2 percussors in every room. I think Dr. Brett still does. And you turn them both on. Now, like that. Sacrum, third lumbar like this. Bilateral infraspinatus here. Bilateral shoulders. Third cervical, third lumbar. You talk about melting somebody. They just melt. So, and Dar and I, when we were really developing all this technique, a lot of times we'd do double treatment. They'd be on their back. I would start at one knee, she'd start the other. When we were really getting it, we would just do the whole patient up. They'd be like, you know, limp rags when you're through. It's great. But you can do a 2-headed technique, face down like this is really fast. But it requires 2 units. Or if you have 1, you still do it. You come right in on the second sacral segment. You release it here, come out in here. You still can hold back with the listening hand. Nothing wrong with it. You just don't have quite the motion. It's a different kind of a release from there. Okay. Sit up and face them again. Just to go over shoulders, because nothing better really for a tough shoulder once you clear out that neck than here. You come in, so if I want to release the whole shoulder, I can come right in the acromioclavicular articulation. I come in like this, and I just hold it like that. My listening hand, remember the listening hand's the most important part. It has to resist that motion. It just does a dance in there, so I completely get it to release. Coming right top on the shoulder is really important. And the listening hand is more important. Like, you've really got to hold them. The more you hold them, the faster the release goes. If it's a real cute girl, I get down like this. This guy. Might as well use it to your advantage. But the more points you can hold them on, the better you get. The top of the shoulder, acromioclavicular, sternoclavicular. One thing you never want to do is a sternum before you've done the back. Fulford was really big about this. The manubrium itself right here ties into the sword proper. This, according to him, is where the egg and the sperm met. That's where they all got together. The mulberry mass grew from there, and the whole body became. And all of the seeds of emotion are right here. So if you're ever going to release that with the percussor, you always want to do the adjuster in the back first, or at least percuss this area in the back here first. Release it. Then come up here and release this. Incredible emotional release takes place when you do that. It's like shock release, but it's deeper. Because again, I don't know where he came up with that, but he said, when the egg and the sperm come together, everything grows out of that. So here's where all the emotions are. So find out what we did about him, something in the room, that'd be a great thing to do for him, and kind of watch it. Do shock release and do that. Percussion-wise, once you flip on the other way. On the cranium, we would go ahead and stay sitting because I wanted to see it. We would do it lying down, but my contact points are going to be right here. Everybody feel the back of the knot on your head, the EOP, external occipital protuberance. That is an incredible release. Goodhart taught us to do it, in the old days before I learned percussion, you pump in and all that stuff. But boy, if we're changing it, turn it way down to 3 or 4. The percussor, center of the plunger goes right on the EOP, the listening hand goes on the frontal. They'd be lying on their side. I could do it this way, most time they're lying on their side. And I come into that point, and I feel it tense. You'll feel the cranium, when it releases, like, whoa, it's like a crescendo. Chronic headaches, migraines, auto accidents, it's just amazing for that. Now, normally what's going to happen, if that one shows up, we call it EOP, external occipital protuberance, to the glabella. So you come up here, and take a deep breath in through the nose, hold tight, don't let me go away, breathe out, don't let me go away. Okay, if that got weak, it's an inspirational cranial fault. To correct an inspirational cranial fault, you come to the top of the head, right to the point where the ears point to. So my listening hand would be back here. Again, they're laying on their back. I would come right in the center here. I'd percuss that. That opens the whole cranium up from this way. Now, breathe all the way out. Breathe in through your mouth. On there, actually pinch the nose off. In through the mouth now. Hold the breath in. Don't let me go away. If that gets weak, his does not, that's why I do the glabellar fold. And I would come here on the EOP, coming out the metopic suture. That's what this is called, because as a baby, these are 2 separate halves, the frontal bone is. That's called the metopic suture. As you mature, those become one bone, the frontal bone. So lie on your back, let me show you what that looked like, because he had an inspirational cranial fault. When breathing in or out through the nose makes you weak, you do the top of the head. This is on the test. You breathe in or out through the nose, you percuss the top of the head. If you breathe in and out through the mouth and get weak, that's what I should say, breathe in out through the nose and get weak, you percuss the top of the head, right here. Nose points to the top of the head, see it, right here. Where glabella fall, in and out through the mouth says you come back where the breath goes is here. So he got weak when he inspired, when he got weak and or breathed out. So I turn it down all the way to what on the cranium? 4, 3, 4. The listening hand goes underneath the cranium here. Here we come, right here on the top of the head. So I'm winding that up. It's building, building, building. It's pretty tight in here. Still building. I feel emotion trying to come out here as well. Building, 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 still building. And there it goes, there it goes, there it goes, there it goes. Still going, still going, still going. Now there's energy there. Wow, finally goes. So we will practice that. You will all feel that before the day's over, or Dr. Scott doesn't get to
So it's not so important whether he's breathing in or out, his student knows it or not.
That's correct. AK makes all the difference in the world, which way you rock the cranium. Okay? If you inspire and you get if you get strong when you breathe in through the nose, and then you get weak when you breathe out, you have to rock the head forward as you breathe in. But that's kid stuff compared to what we're doing. If you breathe in or out through the nose, It means that's the part of the cranium that's locked up. When you percuss it, it corrects it all. You breathe in and out through the mouth, you can do it right here, that's a glabella fault, it releases the whole cranium. I mean, 100 times what any 8K move could do. Turn facing me over here. And I'm a diplomat, I'm not being rude, I'm just telling you fact. A lot of the 8K stuff with cranium, you have to be careful of because you know how it is. If one guy does an 8K test, he might get it slightly different than the other guy. And you start forcing bones by what you find with muscle testing, you're asking for problems. Where if you release it and you feel it tight and it turns loose, it automatically corrects itself. This is way better technique. That's why I introduced it to the ICAK, and I got the highest honor you can get in the ICAK called the Adrenal award for it. And but very few of them ever really learned to do it right. If he had a glabella weakness, breathing in and out through the mouth, I would come right here on the external occipital protuberance and look at my. Can you see where it is? I'm on an angle like this. Why? Because the EOP on him is down below, so you're actually pointing it towards the metopic suture up here. It has to be down here. But everybody's has a little bit different. So if he was here, I would be here. I'd have to move it to where I'm right on the EOP and I'm staying level. You always, if I was going to do the scapula, it'd be here. I'm doing the vertebral border, it would be here. If I'm going to do the spine, it'd be here. You want always flat when you're contacting with you, never out on the edge or anything. So EOP to the topic would be right here. Percuss in, try releasing right there. Everybody see that? I'm right here, bringing it up there. Yes, sir.
Any special procedures where you actually use a sciatica?
All this ties into sciatica. You always have to check the piriformis muscle and the gluteus medius maximus and minimus, and those tie into this upper cervical area. And then in our office, we put them on the magnet charge or the EM90, and that occurs almost 100% of them. So sciatica a lot of times can be the muscle trapped inside there. But you clear out the disc, you clear out the spine, you clear out the cranium. I don't know, can you remember a sciatica? Where's Dr. Brett?
Over here.
Have you cleared out sciatica you couldn't help? I can't think of one
There's
right
stenosis, then I have to do a lot.
What's that?
Stenosis, unless there's a lot of
Yeah,
stenosis.
stenosis is about the only thing that does it clear right up. Like he says, if you don't not see a major difference in 3 visits, you wonder what you did wrong.
Yep.
But think of the difference here. He's spending 30 minutes to an hour where he's going to spend 7.5 minutes with somebody. He can get different results as long as the patient knows it's going to be $300 for that hour. Sometimes you get better results than $300 seeing them over several weeks. But it's the way you like to practice and the way the patients are geared to the way you practice. I really got to where I love long extended visits because I could just resurrect the dead almost with that. I had enough time. I didn't feel rushed. I saw 15 patients in a day instead of 50. You know how much more relaxing that is? And the problem I found, when you know as much as we know, you have to design how do you break it down and have your CAs do a lot of it. You just do your part, the smart guy stuff that Greg Jacks talked about, which is what we do, and then have them to do everything else. Or you stay right there until it's done. Both of them work wonderful, has to be a different price tag. Because some of the docs started learning this work, they went back and instead of seeing a patient for 7 minutes, they started seeing them for 70 minutes and still charging $50. You can't do that. It's got to be $300 for the hour. Any chiropractor has to generate $200 an hour to make a living. If you're not generating $200 an hour, you're killing yourself. That's what my numbers say. But Randy just looked at the statistics. The average chiropractor now is making under $60,000 a year. That's a bad month right there. It really is a bad month. I'd have cried my eyes out. Would you, Dr. Jesse? Yeah, that's a bad month. But in a year, I mean, it's more than that. It's more, I think a lot of them around 30 to 40,000. And you're talking about malpractice, and you're talking about health, insurance for your health and unemployment and all that stuff. That's why a lot of people are making. But I think the majority are under 60,000. And hopefully none of you are in there, then you definitely don't have to be if you implement this. Dr. Brett's brother, what did he bill out last week?
Week?
What did Brock bill out last week?
And he told me like 180 or something like that, 140, yeah, 140.
He billed out last week $140,000 in a week. He's a dentist, right? Like I've always said, when dentists, the first semester, they remove their heart. They know how to charge. I had to have some oral surgery, and the bill for one day in the chair, an hour and a half. They had to extract some teeth, so I had some bad dental work, and they killed some teeth. And I had to have 2 teeth extracted and destroy a bridge. And they tried to do some implants in it, and they actually died off. I think it was $7,000 an hour now. And he didn't even say, I'm sorry, or I apologize. It's just, that's the way it is. You want to hurt like this? You know? I mean, that's the good thing about dental pain. It's so bad, you just dig into your wallet, pull out the plastic, whatever it takes. But, I mean, here's a dentist. He's a punk kid. He's only been out of school 2 or 3 years, right? And he billed out $140,000 last week. And what do we have to complain about? Come on. We have more to offer anybody on the planet, but it's got to drive your economic engine too. All right? That's all you get for $5,240 we give you. Thank you for your help. We have 7 minutes. So when we come back from lunch, we'll all meet in here again, and it might take us slightly over. There's just, you can eat right out here, and there's just restaurants everywhere out here. But they have food 24 hours a day in here. I think you can order them. But when we come back, we're going to practice this a little bit. Then when we break up all afternoon, we're going to work on 3 things: adjuster, percussor, and nutrient testing. Then tomorrow, first thing, we'll go over all the nutrients, the ones that we use now, and the new ones I developed, and we'll go into, hey, when we come back for lunch, I want to go over the halogen testing, I want to go over the heavy metal testing. Well, let's just talk about the basics. So open your book up now to the nutrition section. Everything is categorized here. You see it's much skinnier now, but on the nutrition section right there, it goes right through there. There's actually a section in there that talks about B complex, and it talks about this one sheet that they've given you. It talks about why the products I use now, what's different about them than the ones I used before. I think you'll find that kind of helpful. So when you're eating lunch, you can review that. You've noticed also in the book, I've had them put in a couple of these for practice sessions. So as we're taking notes, the nutrition isn't by there. And so you can just look at all those different points in there, what they are, and you can jot the different nutrition aside as we discussed it over the weekend. It's in your book as well, but I wanted to have a few practice there, because I'm going to tell you what you're going to find out on the examination. You're going to see a picture like that, and it's going to have those little dots and blank lines. You're going to fill in the lines out the side, because I want you to know what each one of those points are. Okay? And what a nice teacher to give you all the answers to the exam information. Ashamed of myself. What height when we go down? Here's what we want to do. We want to do the muscle testing, and to do that, you want to do, are you testable? Right where the nose joins the head right there, we should get weak when that happens. She is not as tight as I'd like to see it. Okay, she got weaker. Yeah, I always check it with the glasses first. Then I would say, well, let's make sure it's not the glasses. Why would the glasses might concern you? What do you see about the glasses? They're all metal. They're metal here, they're metal here, they're metal across the center. So I might take those off to see if that doesn't help a little bit. But I already felt Richard to get better. So that is better. But I do it first because I want to know if the glasses bother me. Okay, so we know the next time she gets her second set of eyes, they need to be plastic like this. Those aren't going so bad. I'm going to tell her to throw them away because they're expensive, but I definitely never get metal across it again. I'm going to stay to plastic. So she's testable, but is she switched? They come right here with this collarbone joins the sternum, and this collarbone joins the sternum. That's called K27. And the kidney meridian. It's the beginning of the internal meridian that goes to the bladder meridian back here. So that's a major point. If I touch either side individually, it should stay strong. If I touch both of them collectively, it should stay strong, but it's not. So that means she's short-circuiting across that area. That's what's called switching. Switching means neurologically disorganized. Now, there's all other kinds of switching. I'm not going to hold you accountable, but I just want you to realize that. Touch your belly button.
Can you do that over again?
Sure. She just touches her belly button. I told you about it just a minute ago, go down. If she touches there, and I actually touch her brainstem at the same time and she gets switched, that's a different kind of switching. I probably shouldn't even show you this. Touch your tailbone. Touch your tailbone is okay, but her tailbone, and I touch right at the top of the head, and guess what? That's another kind of switching. She shouldn't have any of this stuff. But what we're doing here is we're checking the collarbone. Here's the collarbone. It joins in the sternum here and here. I should be able to touch them individually and stay strong, or collectively and stay strong. And and she gets weak, and this is the test, when I check them both together, does she go, yes, she does. So she's neurologically scrambled, something's wrong.
My question was, if you found them, so they're wearing a magnet, and they come in and they forget they got the magnet and test it, does that really matter?
That doesn't matter, because the magnet really has nothing to do with, if it's on, I mean, it will help clear it up in a lot of people, but as long as they're wearing it, I don't worry about it. So I don't always take your magnet off. I just don't want to worry about that. Do you have a magnet on? Okay, so, and it's still a problem, so the magnet isn't enough, something else is making her scramble. That's a good point. Then what? Well, if she's not testable or is switched, I go to the next two things. I then do adrenal stretch. Hold tight, you want to go down. And she shouldn't get weak, but she does. So as she gets weak, what we normally have to give her when we do an adrenal stretch and she goes weak. Right, we give her max adrenal results, BSF. So I'm actually going to check her now, since I'm in the mode to find out what she needs nutritionally. I'm even going to ask her, do you want max adrenal herbal or max adrenal glandular? And they check equally well, or we don't. She got weaker on max adrenal herbal second test around. Why didn't it show up that way first time? Huh? I think what I did, I gave her the glandular and she was strong. I mean, I gave her the herbal and she was strong. I gave her the glandular and she was strong. Then I gave her the herbal and she was weak. I asked her different questions. When I give her the herbal first, is the herbal good for it? Yeah. Is the glandular good for it? Yeah. Well, is the herbal as good as the glandular? No. When I went back that next test, that was the other answer. Fair enough? Anybody confused on that? So she chose the adrenal. So that's good. Let's have a whole thing on how you choose adrenal. So we got that, we're ready to go. Does that solve this problem? Yes. Does that solve the switching? It does not. Well, poo. She has a magnet on, but she's still weak. And I come here, so it looks like she needs a little extra electromagnetic protection. Where did I put that? Set it over here and put it back. Say, what's that?
It's an amulet, it's a Buddhist thing, so.
That's a good point though. Okay, I'm gonna come here, and I'm gonna go here. Okay, and that does strengthen her. However, take that off for just a second. Anything they have on could affect them, so that's a really good question. Now, I just messed up my indicator because I gave her the second magnet. But if we took that off and she went strong, you may, if it's just an ornament, then you would have to take it off. If that's holding the weakness in, you're going to have to neutralize it. Is that like for religious purpose you wear it all the time? Okay, so I think this has taken on some of your toxins and you haven't got rid of them. So what you can do is when whoever checks you back on the machine, they can put it in the well and they'll neutralize it for you and rewrite your script in it. So pop a bear and you get one of the machines, and then every time that you reprogram yourself, put this in, because you're bringing your negative energy into here, and then you're reprogramming the negativity. That's what that shows me. And these bracelets that you have, everybody's wearing these different bracelets out there that have all this magnetic imprint in them. They hold the negativity. When you first check them, they're really strong. Check them a week, 2 weeks later, they've taken all the negativity in, and they're wiping them out. Now, if you have the machine, you can put them in there and reprogram them. If not, I don't know how you reprogram them, because they hold on to the negative. Okay. Not run over here.
Would you also look for ear lines?
That wouldn't solve that. I mean, it could, but that's not the real issue here. Now we do that and we're ready to go. Now that we've done that, she's ready to test. So we go through the regular points, and most of you should know all those. Look at lunchtime. We're going to check the liver, gallbladder, cystic, gut. Good. We're going to touch the circle so we don't get heart. Heart's a problem. So just make a note of these for more efficient facial. Let's just flip it over on the back somewhere where you don't mess that up. In their chart, does everybody have some?
No.
Okay. So we'll have these $10 at lunch, just where we know where they are. All right, so check heart, we're going to check heart. Now we're going to check homocysteine. Okay, and she has a homocysteine problem. So she doesn't have enough folic acid methyl donor, B6, B12, you know, most often it's an activated form of folic acid. That's what I can very interested to do. Where Zymogen has a quadrotetrahydrofolate. It's 4 steps past regular folic acid. And a massive amounts of this cannot take genetically folic acid and convert it into the active form. So Zymogen has a formulation they've taken down for this. I think they have it trademarked or patented where nobody else can have it right now. It's like instant and makes a big difference on that. So we're going to give a folic acid, what we would call in the old days homocysteine redux. It's still the best product in the world if they'd given me an activated folic acid, which I wouldn't do. Okay, so that's going to be a problem there. Right here is the lung, so let's come up here. Right where this little pocket is right here, we come here, and here that's lung. No problem with the lung. Come down to spleen, come down to pancreas, come down to stomach, small intestine. Uh-oh, we have a leaky gut. So that's a problem. How about large intestine? You hold real tight. Ascending, transfers, descending. No, it's small intestine. How about bladder, uterus, ovaries? Ovaries, we go weak. All right, so we have weak ovaries. Gosh, I wonder how our pituitary is. Hold tight. By itself, it's okay. How about the thyroid? No, we don't put it out of it. So no good for nothing. We have a thyroid problem, we have an ovary problem. We have to check her for a female balance. We have to check her for her ability to use iodine. And that's a big deal. This is that Nobel Prize I'm shooting for. I want you guys to write me in. So we have a product called Max Iodine. Now, she needs iodine in every tissue of the body, every cell. I can pull iodine on her now, hold that number down. She's weak. She can't even use iodine. She needs iodine and can't use it. Can't lose weight that way. Energy level comes up. I mean, it's a vicious cycle. So we'll fix it afterwards. What else you want? No, I can't. You're right. He knows it. Hold tight.
Can I put this one down?
You're okay. You're fine. Okay, so we say, what happens there? Well, that makes her weak. That's chlorine. I check her here, and that's bromine. So bromine's okay, but the body can't tolerate chlorine. Well, if you can't tolerate chlorine, the chlorine you're getting every day in your water and your swimming pool and everything else. So I percuss it because it's a homeopathic. I count 1, 2 drops. So I'm going to do 2 drops under the tongue. In fact, before I do that, real quick, let's just check range of motion here. Okay, not bad. Harry's a good chiropractor. Pretty dang good, but a little stiffish there. Lie it back real quick. Hands down on your side. Just relax here. That's it. Very good. Chlorine. We give her these couple drops under the tongue. Just let that kind of work there for a second. Number one thing I found, once you trigger the homeopathically the release of the halogen that's toxic to the body, hold that here, she'll now be able to tolerate the iodine. Energy level will come up. Thyroid will test, hold tight, better. Ovaries will test better. And help prevent breast cancer and ovarian cancer according to lab recs on all the research that they've done. Instantly though, when you start to release the toxic halogens, here's what you do to the range of motion. Remember where she was a minute ago? Right here. I mean, how could we dare be missing this? We just gained another, this side only went to 90 degrees, that went to 120 degrees from 30 degrees, instead of face that way. And this will be just like water. That's the key we've been missing. That's big time. So what we're going to have her do is take 2 drops of chlorine every morning before she takes her iodine. Make sense? But what we're finding is when you remove chlorine one day, for 2 or 3 days it'll show, and then it'll show fluorine, and then bromine, and Zymogen is making me a fluorine, which I can never get done before. But right now we'll have her buy fluorine and chlorine, take 2 drops each morning, one day, one the next. And that way it keeps it going, and then take her iodine. By doing that, your whole world will change. Energy will come up, say weight loss will be easier, sense of well-being, protect the breast and ovaries from cancer. It's pretty scary right now.
Then how long would you do that with her for before you pull her off?
Well, I'm going to check her. I'm going to check her every week or every month, whatever I'm doing. But I think it's a lifetime process. One iodine a day. There's 12.5 milligrams of active iodine, which is maintenance dose. If I did some testing on her and it didn't come up, I'd kick it up to a couple. But we found out by doing it that way and getting rid of the halogens first, it's been very good. You should have iodine every day in your life. Our diet does not give us enough iodine. The testing that's being done by JB from LabRex, he's finding over 98% of patients are deficient in iodine, over 90% are deficient in vitamin D. But now that we found this halogen connection and you give him the iodine, it's now working. He feels like we'd have almost zero breast cancer and much less ovarian cancer, and men would have no prostate cancer if we solved the iodine problem, which we've just solved. So far, we only figured this out this last year, but I think we're on top of something that will revolutionize the world. Why do we have so much problem now? Because we're pumping bromine, fluorine, and chlorine. I mean, how many people use a fluoride toothpaste every day? 90% of America. How many people have chlorine in our water? Every single one of us, let's just drink all bottled water. How many people have bromine in your peanut butter, in your breads, in your, everybody, unless you know about it and you're not eating it.
So you have her doing the drops indefinitely?
Until the body would tell me otherwise. But so far, I've been doing it for a year. I've never seen anybody who completely wants it. Now, I check myself every day, I'm 90 every day, and we'll do it, day, and all of a sudden, like, I don't want today. Next day, maybe not, but the next day it will. Or we've been doing it for months and months now. But where people don't know how to test it, I'm probably just gonna have them rotate through chlorine one day, fluorine, bromine the next day, and until we figure it out. Right now, we're still in the developmental stages here. Randy found a blog since I've been gone for a week, and she said, go on this blog. Here's a guy who has a blog on bromine poisoning. He did the same thing about chlorine or fluorine like you do. He says he's stealing a lot of your thunder out there. He has 1,000 followers or thousands of followers showing how bad bromine is, but they don't have a clue what to do about it. We're on something big. I'll show you a bunch of people. We'll check everybody before the weekend's over, and you're going to see it'll make a difference in whatever you're treating on patients. Sir?
How long do you wait to take the iodine after you take the?
Just right then during the meal. I do this first thing in the morning and then just have to take it before the breakfast is over. It just seems like the main thing is they have to take that first, but the homeopathic doesn't tell the body says, oh, they start dissipating it, and you take it, and you seem to be fine. There's a girl on the board with us, Zymogen. She's a nutritionist. She's actually taken my course when I taught up there for the other company, and so I've known her for a long time. But she just came once or twice because she couldn't use that product and been with Zymogen now for quite a few years. But I met her at the seminar, and I introduced this when we were in Canada last month. And she came up to me and she says, I haven't told a lot of people this because I don't want to sound like I'm a whiner, but I kept reading the literature of how I needed iodine. And so I took the iodine, the Lugol solution, some of you probably know about that. And I had like palpitation. I thought, look, you need it, you just take it anyway. And she like triggered a massive heart attack. And she said, now I see what you're showing me, I know why. Halogens are in a group on the periodic table, chemical table, they're all together. Fluorine, chlorine, bromine, but where is iodine? It's an itty bitty boy down here. Okay? Fluorine is like Ruka. They walk this so big, you know? If you go there, you only have one crumb of bread, who's going to get it? Ruka, he's not going to let Brimhall eat at the table, right? These big muscle-bound fluorine. Fluorine is the most electromotive substance on the periodic table. I remember studying that when we were going, wow, that fluorine, that's pretty wicked stuff. I wonder what it does to the body. Now, 40 years later, 44 years later, I'm really seeing what it does to the body because it displaces everything else. So now here comes iodine trying to dock on the station to form thyroxine, and the fluorine says, yeah, right, come on in. You think? No way, man, you ain't getting in. So the cells are not getting any iodine, and you try to force them in by taking it, it causes an adverse reaction, evidently, to the fluorine, the bromine, and the chlorine in the tissues. It causes some people massive reactions. But when we've been doing this, we've been getting phenomenal results. It was just one quick case. I try not to see too many patients, but when I got my Colorado license renewed, so I can see him in Colorado. They sent me this patient, guy had migraines. He's like 28 years old, had migraines his whole life, all kinds of drugs and meds. And so I checked him. The first time I checked him, he showed uranium. And I think he might have shown uranium twice in a row, plus the halogens. And then he showed, I don't know, aluminum. Anyway, the first visit, his migraine went away completely right on the table, came back. Next visit, a week later, I corrected it. It came back. Next visit, third visit, I corrected it. He's never had another migraine. That's been like 3 or 4 months ago. So it's very powerful stuff, what we're doing here. Say hello to so we'll just go to lunch, and then we'll come back and we'll take off right from here. We're all meeting here, and so take off. Come back close to hours you can get here, okay?
Is this thing recording right now or no? It is. How do you turn it on?